Hello, my name is Paul Fletcher. I'm a periodontist and associate clinical professor at Columbia University, where I teach implant dentistry and periodontics on a postgraduate level. This video is being placed on YouTube at the request of those who have attended my lecture on the management of peri-implant disease. It summarizes the slides of the presentation so they can review the material at their convenience. The video will also be valuable to any dental professional who desires to learn a research-based, in-office and at-home protocol for the treatment of peri-implant mucositis. And the final 10 minutes will be of special interest to any patient who's been told they have bleeding or they're beginning to lose bone around their dental implants. Peri-implant disease is a very controversial topic. There are some excellent clinicians and researchers who don't feel they see peri-implant disease all that often and it's just a minor inconvenience, where there are others who think it's becoming a major problem. I'm one of those who are beginning to feel we have a problem. I feel we have a problem because at Columbia University, hardly a week goes by when another student doesn't approach me with a new case of peri-implant disease. And in my private dental practice, where literally half of the new patients we see are due to some form of implant-related issue, we're also seeing the number of new cases of peri-implant disease increasing. The research also seems to say we have a problem. The research is telling us as the number of implants that have been placed increases, and as the number of years implants have been in place increases, and as dentists with different skill sets are beginning to place implants, the incidence of peri-implant disease is increasing and the prevalence of peri-implant disease is increasing. Those are the signs and symptoms. Now, when we take a look at an implant with mucositis or peri-implantitis close up, and this is a scanning electron micrograph, what we see here are the pores of the implant, and this is bacteria attached to the implant and embedded in between the concavities of this implant and the pores of the implant. There's no way that you can get in there mechanically to remove this bacteria. It's embedded. Mechanical therapy alone is inadequate to predictably detoxify an implant surface. That means that cleaning an implant surface is not a monotherapy, but it's a bitherapy. And besides mechanical cleaning, what we get involved in is chemical detoxification of the implant surface. So the goal of our treatment is surface decontamination, both mechanical and chemical. And our objectives are basic microbiological objectives: disrupt the bacterial plaque biofilms, detoxify cell components affecting the growth on the implant surface, and reduce the bacterial load by dilution to a level that will allow healing. Basic microbiologic principles: dilute, disrupt, and detoxify, with our objectives and our goals being to eliminate bleeding upon probing, the primary objective, reduce pockets if possible, and stabilize bone levels. And that's what we're looking to accomplish when we treat these areas mechanically in therapy. So, finally, at-home prevention and treatment of mucositis. It's all about controlling the biofilm. That's what's most critical. And you have to tell the patient, our objectives are, we've cleaned the underside of the implant, the subgingival aspect of the implant. Your responsibility is now to stop the supragingival bacteria from migrating subgingivally. So objectives: minimize subgingival migration of supragingival biofilm and keep the subgingival biofilm below an inflammatory threshold. That's what we're trying to accomplish. And here's the at-home regimen. Optimal home care is imperative, and you have to explain that to your patient. I find implant patients to be much more compliant than my periodontal patients. These patients have lost their teeth. They spent a lot of money and time getting them replaced with implants and implant restorations. And now you're telling them they may be in danger of losing the implants. So most of them are ready to do anything they can to maintain the implants. And what we're asking them to do is really basically something very simple. All we're asking them to do is brush their teeth and rinse their mouth out. And we're asking them to brush with the triclosan dental frizz. This is Colgate Total toothpaste in the United States. Triclosan dentifrice, the total, has been shown to reduce inflammation, bleeding upon probing, and 5 millimeter pockets over the course of 6 months. Again, we're seeing the patient every 3 months. There's less plaque, there's reduction in gram-negative anaerobes also over 6 months. Much research on it. We're also asking the patient to rinse their mouth out with a mouthwash. And they can either use an essential oil mouthwash such as Listerine or acetylpyridinium chloride mouthwash such as Colgate Total mouthwash. The essential oil mouthwash, research shows less plaque and bleeding upon probing than a control, but no changes in probing depth. But we are reducing the bacteria. And the good thing about the CPC mouthwash, it has 12 hours of substantivity, it stays on the mucous membrane surface, and there's no alcohol. You want to use that in patients that can't use alcohol. Essential oil mouthwash, you have to use the Listerine that has alcohol in it, so to speak. So here's the home care regimen. As I said, optimal home care is imperative. The patient is to brush with Triclosan toothpaste twice a day, morning and evening right before they go to sleep. Definitely right before they go to sleep. And then rinse with the essential oil or CPC mouthwash twice a day. Once again, with one of the rinsings being right before they go to sleep at night. Because what happens is bacteria multiply when the salivary flow is reduced. So right before you go to sleep, it's necessary to do. The toothpaste will in fact clean the area around the implant, whereas the mouthwash is going to take care of the bacteria on the mucous membranes, on the soft tissue, in the back of the tongue, and on the throat. If you can get the patient to floss, use an end-tuft brush or interproximal brush is even better. And the final thing you're going to have the patient do is if they have a framework in their mouth that's difficult for them to get under there and keep clean, you're going to give them a monojet, plastic monojet syringe with a plastic needle to take home or a plastic tip to take home. And you're going to tell them to irrigate with sodium hypochlorite in the monojet syringe 3 times a week around and under the frameworks. And the concentration you're going to tell them to use is you're going to tell them to take 1/2 teaspoon of sodium hypochlorite, which is 2.5 milliliters, just a half a teaspoon, and you're going to tell them to put it into 16 ounces of 500 milliliters of water and make that type of solution, and then use the monojet syringe to irrigate as best they can under the frameworks of the implants. And that's what we tell our patients to do in order to treat the mucositis. To summarize, early interceptive treatment is imperative in the patient prone to periodontal disease, especially. And the best treatment for peri-implant disease in 2015 is prevention. So I can't emphasize enough how important it is that you give the patient an at-home regimen for brushing around their implants and treating their mouth to prevent mucositis from progressing to peri-implantitis. So I hope you got something out of the presentation. Feel free, if you have any additional questions, to contact me, Specialized Dentistry of New York, at pfletcherdds@gmail.com, and my phone number is 212-752-7937. I'll be more than happy to answer any questions you may have, and I hope you got something out of this presentation.